So I'll be assessing the frontonales. So the first frontonale that I'll be assessing on the head is the anterior frontonale, which should be palpable, and it should be a diamond shape. It is the largest frontonale on the baby's head. It should be soft and palpable and flat. It should have no bulging or sinking. Then I'm going to um, assess the posterior frontonale, which is the triangle shape. These frontonales should be within 5 centimeters or average shape. Also, the sutures should be palpable and separated, and they should not overlap, which could indicate molding. So we understand that the head is usually compressed during labor, so that's the reason why we would assess the sutures on the line, so we can understand that there's no cephalohematoma or secretum on the head. So we want to make sure that there's no swelling or softness tissues of the scalp, which indicate the caput secretum. And this can usually be resolved within 3 to 4 days. And with this one, the suture lines can cross over, and it doesn't really require any treatment. Also, if they had cephalohematoma, this will be a collection of blood in the head, which will cause like bruising or trauma due to like the pelvis, the maternal pelvis, or prolonged difficulty in labor, or using like forceps during delivery. And this usually appears within 1 to 2 days after birth, but can be resolved in 2 to 3 weeks. So after that, I'm going to be assessing the face of the newborn. I'm going to be looking at the eyes, making sure that the eyes are symmetrical and equal within size and shape. I want to make sure that the eyes are 1/3 the distance from the inner canthus, and making sure that they match the pinea of the ears. So making sure that the inner canthus lines up with the pinea of the ears, which is the top part of the ears. Otherwise, this can indicate any form of Down syndrome if it does not. Then I'm going to making sure that the eyeballs have symmetrical movements and there's no jerking or involuntary movements in the eye. So then I'll also be assessing the ears, examining the placement of the ears. I want to draw an imaginary line through the inner or to the outer canthus of the newborn's eye. And like I said, this should match the upper tip of the pinea of the ears, so that it doesn't indicate any Down syndrome. This baby appears to be normal, and the inner canthus to the outer canthus of the ear matches the top pinea of the ears. And then I want to be making sure that the baby can hear and responds to sound very well. Then I want to be looking at the nose. I want to make sure that the nose is midline and it is flat and there's no lack of bridges. I want to make sure that the nose is free from any blockages and the nasal passages are clear and the baby is able to sneeze. So I would, just hold one nostril down at a time, making sure the baby is still able to breathe. Hold another nostril down at another time and make sure that the baby can breathe. And the baby's nose and nasal passages are indicate to be clear. Then I want to look at the mouth. I want to check around the mouth and make sure that there's no cyanosis, any blue discoloration, which will the baby appears to be normal. She has pink color around her mouth and her mouth is moist. I also want to be checking the saliva. I would put one gloved finger in the baby's mouth to check the palates, making sure that there's no holes or opening in the soft palates. And also when I do this, I could be checking the sucking reflex of the baby, which appears to be great. I want to be checking the gums, making sure that they are pink, and checking for gray or white patches of thrush, which can indicate thrush on the gums. I want to make sure that the baby's tongue is not protruding, which can indicate Down syndrome as well. I want to make sure that if they are small white cysts on the gums, this is normal finding in the soft and hard palate also. Then I'm going to be checking the baby's neck. I'm going to be making sure that it's short, thick, and surrounded by skin folds. And the neck is able to move freely side to side. The baby's able to move, which is great, and up and down. And I want to make sure that there's no absence of head control, which can also indicate Down syndrome as well. Then I'm going to be checking the baby's chest. I'm going to make sure that it is a barrel shape and there's no absence of retractions. We also know that the baby breathes primarily, the respirations are primarily diaphragmatic. The baby's breathing from their chest, so we want to make sure that there's no retractions. I'm also going to be assessing the baby's nipples, making sure that the nipples are prominent and symmetrical, and also looking at the breast folds and nodules and making sure that they're either 3 to 10 centimeters in size. I'm also going to be checking the abdomen, looking at the umbilical cord. The umbilical cord should be odorless and have no signs of internal structures or redness or foul odor. Making sure that the abdomen is round and in a dome shape. I'm also going to be auscultating the bowel sounds, so I will have my stethoscope. I'll make sure that my stethoscope is warm before placing it on the baby's abdomen. And the bowel sounds should appear between 15 to 20 minutes following birth. So I'll be auscultating the bowel sounds as well. I'll also be assessing the genital areas, making sure that there's no meconium after birth. If it's the female newborn, I'll be assessing the genitalia area, making sure that there's the labia minora is covering the labia majora is covering the labia minora and the clitoris, and that there's no edema in that area as well. I want to make sure that if the newborn is having vaginal discharge or bloody tinged discharge, this can appear to be normal as well due to the maternal pregnancy hormones from the mother, which is also considered an expected finding. I want to make sure that the baby has urinated within 24 hours after birth, and that the urine is like a rust color, and there's no foul odors or any signs of infection. Then I'm going to be evaluating the extremities. I want to assess for full ranges of motion. So I'm going to start with also checking the clavicle of the baby, making sure that there's no deformities, because this can indicate clavicle fractures. I want to assess the arms of the baby, making sure that there's free range of motion in the arms, moving in and out, rotating the arms, and the baby has free movement. And while I'm assessing the arms, I could also assess the baby's finger, assessing the grasp of the finger, making sure the baby's able to have a normal newborn reflex in grasping my fingers. I also want to assess that the newborn has 5 fingers on both hands, which it appears to. I want to also assess that the baby is not bow-legged or flat-foot. This could be because of lateral muscles are not fully developed. I want to make sure that I assess the legs, making sure that there's no clicking when abducted, because this can indicate that there's a fracture in the hips and the baby does not have any clicking with the hips. I want to assess the soles of the baby's foot, also looking at the folds and the nail beds, making sure that they're pink and there's no extra digits on the baby's foot, that the baby has equal amounts of toes on the foot. I also want to assess the baby's skin for any type of variations, which I think I indicated in the beginning. Making sure that we're assessing the skin the whole time, making sure that there's no any abnormal skin discoloration when assessing the skin. So I did indicate that I checked the sucking reflex when I was looking at the soft and hard palate of the baby. The baby had great sucking reflexing. I'm going to stroke the side of the baby's face. The baby should turn to the direction of the area that I'm touching on the baby's cheek. If I touch the other side, the baby's head should move, which indicates the rooting reflex is normal. So I also talked about while I was checking the baby's arm, I would do the palate grasp when I touch the baby's, put my fingers in the baby's arm, palms of their hands. The baby should grasp my finger and curl their fingers, which is also an expected finding. Okay, so then I also would check the motor reflex. So if I pick the baby up a little bit, the baby's hands should flare out and come back in when the baby is put down, which is assessing the motor reflex, making sure that the head and the trunk of the newborn is semi-setting position to fall backwards, and the newborn will symmetrically extend and abduct their hands when placed back down. I want to assess